Hi, so for my clinical pattern, I'm going to be discussing slap lesions and slap repairs, or superior lateral anterior posterior lesions, which are injuries involving the tearing or the fraying of the glenoid labrum and the biceps tendon from the glenoid cavity. It should also be noted that slap lesions are classified based on the extent of the injury, which is laid out on my clinical pattern. To repair it, the surgeon makes several small incisions around the shoulder joint and inserts an arthroscope to examine the condition of the labrum. Instruments are then inserted into the incisions and are used to remove the frayed edges of the labrum if the tear is small, or repair and reattach the tendon if the tear is more severe. And repair is also usually done with small anchors attached to the bone and sutures to secure the torn labrum. So the most common age group that slap lesions occur in is between the ages of 20 to 29 and 40 to 49. And then as far as gender goes, in a study of like 25,000 cases of arthroscopic slap repair, 75% of the patients were male. And a good outcome tool to use for this is the disabilities of the arm, shoulder, and hand, or the dash. So slap lesions usually occur due to acute trauma, either compressive or tractional forces, or repetitive overhead throwing. Some aggravating factors for the slap lesion itself, not for slap repair, include overhead activities, lifting and throwing, and then easing factors include rest, ice, and SEDS. As far as 24-hour pattern, pain will increase throughout the day with aggravating activities, and it could potentially increase during the night and upon waking, depending on the sleeping position if it was more aggravating. Do we need a systems review for this? Maybe. We really just want to ensure good screening that would rule out any non-musculoskeletal sources of symptoms, such as like liver, spleen, gallbladder, lung, referral to the shoulder. And then we have a good many precautions and contraindications for initial eval of a slap repair. So we do not want to do any shoulder active range of motion or active assist. We want to keep passive range, external rotation less than 30 degrees, glenohumeral reflection less than 90 degrees, no extension or horizontal abduction past the body for 4 weeks. We want to avoid combined external rotation and abduction for 6 weeks. No elbow active range of motion, just to avoid long head of the biceps tension. No lifting, no supporting body weight through the hands, no reaching behind the back. We definitely don't want to do glenohumeral mobilizations, and we also would like to limit running and jumping due to distractive forces on the glenohumeral joint. As far as the physical exam, active movement testing, we really just want to do gentle active to active assist range of motion of the elbow and wrist only. And we would expect the range of motion to be within normal limits for elbow and wrist only. We are definitely going to be limited during passive range assessment just due to stiffness and pain, but we want to make sure that the patient has range within safe limits. We have no need to perform any resisted testing, accessory motion testing, neuromobility, or special tests post-op, and we definitely don't want to be resisting the glenohumeral joint, so definitely avoiding all of those things. And then during palpation, do keep in mind that the patient could potentially be hypersensitive along the axillary nerve distribution. So just keep that in mind when handling, and we also want to avoid palpating incisions until they are fully healed and the sutures have been removed. There should also obviously be expected tenderness to palpation of the surrounding musculature post-operatively. Differential diagnosis, not for the repair obviously, but for the tear itself, can include rotator cuff pathology, subacromial impingement, and biceps tendinopathy. And then as far as diagnostic imaging goes, there's pros and cons to each type that I found, and there's also conflicting information regarding the true gold standard for diagnosing a slap lesion. However, arthroscopy, magnetic resonance arthrography, and magnetic resonance imaging, sorry, I just stuttered over all those words, can be used to diagnose it. And then signs and symptoms indicating referral to a physician. If the patient develops any of the following symptoms, please refer. So fever, unresolving numbness or tingling, excessive drainage from the incision, and then uncontrollable or unrelenting pain. Those are all obviously red flags, and we need to refer. So, yeah.